Joined now by Russel Rensburg. He is the director of the Rural Health Advocacy Project. Russel, good evening and thank you for your time tonight. As far as collective action is concerned, do you feel that there is adequate communication via the various provinces, particularly today focusing on the Eastern Cape, when it comes to decision making?
You know, that's a difficult question. Look, I think we really traveling in uncertain times. I mean, nobody really knows how this pandemic will evolve, but there's quite a few things that we do know. You know, and I think based on what we know, I don't necessarily think that we've adjusted or adapted our approaches enough to deal with the varying implementation arrangements that we have in our different provinces, particularly our rural provinces like the Eastern Cape. You know, so I think there's a lot to be desired in terms of how we've coordinated the response from a national, provincial, and even to a district level. Yeah. And I think we're just learning as we're going along.
And do you think government is repurposing or engaging with the current capacity to be able to scale up the public health system?
Based on current evidence, I don't think so. Right? I think the system was already in crisis prior to going into COVID. We know a province like the Eastern Cape, for instance, have had significant human resources for health challenges. You know, so they haven't got enough adequate staff at primary care, healthcare level, or even at the hospital level. You know, we've had situations in 2015, the Human Rights Commission even held a hearing in the Eastern Cape around the availability of emergency medical services. So the shortage of ambulances and access to emergency medical services is nothing new. You know, and it's been a perennial problem. And I think as we move into this epidemic and we see what's happening in Kisani, and we see what's happening in OR Tambo and Nelson Mandela Bay and Buffalo City, I think this is just the beginning of a much bigger challenge that we're going to need to coordinate and adapt to as the evidence unfolds. So I think now's not the time to be married to particular ideologies, but to try and be as adaptive and responsive to the emerging needs as they arise.
Yeah. With the challenges that are brought on by this pandemic, have you given thought as to how the public-private health system can work together?
Indication, yeah, we've given much thought to it, and I think at this stage the private sector haven't really come to the party in a meaningful way. We saw an agreement coming through in the Western Cape, but the agreement is still set up in such a manner that you know, the private sector only really gets involved once there's an overflow in public sector facilities. And then they also have there's no universal treatment protocols, so people can approach treatment in the private sector at their own discretion. I think we're still operating and responding to this virus, or the spread of this virus, in a very uncoordinated and fragmented way. We don't have any meaningful cooperation with the private sector. But in the Eastern Cape, I mean, a lot of that basically comes to naught. In the rural districts, for instance, more than 90% of the people are reliant on public health services. You know, and the real threat may not even be COVID in the short term, but rather the overall system's focus on COVID could mean that people couldn't access other types of care that they need. We saw last week, for instance, from the Western Cape, and they were telling us one of the major, extenuating factors that can make contracting COVID quite bad for you is the coexistence of diabetes. And we know that in OR Tambo and in the Eastern Cape, we've had the largest increases in prevalence of diabetes. So there are many people who haven't been diagnosed or treated for diabetes, and should we get into a situation where we have a community outbreak of a scale of what we're having in the Western Cape, we might have some serious challenges in the Eastern Cape.
Yeah. Now, when the Minister of Health speaks about a number of beds, for example, he wants to give an impression that says there is somewhat of a public administration of the private sector, because he says, well, when we're speaking about 2,000 beds, we're talking about all beds. In other words, all beds will be made available to whoever is critical at the time when we peak with COVID-19 in the country. Is that so in practice, at a practical level?
I think it's a question where the answer's changing every day. You know, we don't really know how long people will stay in hospital, how long they will need ICU beds. We know we're starting new kinds of treatment in the Western Cape where we're trying to delay putting people on ventilators and rather going with oxygen or nasal-induced oxygen. So I think the evidence and the approaches to doing it changes all the time. I think if everybody needed an ICU bed at the same time, I think certainly we wouldn't have enough. But I think South Africans have shown themselves to be quite adaptive, to changing environments and innovative, and I think some good measures have come out. But we may not just need beds, there are other options of treating patients. But I think the people actually in need of beds at the moment is maybe not as high as what we may think, but it definitely will grow. But I think in a lot of the provinces in rural provinces, for instance, outside of the big metros, should we have challenges there with COVID and even access to other healthcare services, the amount of capacity that we're investing in servicing beds will we could have more deaths from other preventable diseases as opposed to COVID.
Yeah. Talk to me about what you are thinking around an integrated plan of using those facilities. How do we integrate? How do we make sure that what happens on the left happens on the right, what happens in the public happens in a private facility?
I think in areas like in Ireland, for instance, they nationalized the private sector. So they treated the private sector and the public sector as one sector to deal with their crisis. Here we're still negotiating with private sector facilities whether or not they will take our patients. So I think we need to address that. First, that we have to have a universal treatment protocol of COVID based on need and not on ability to pay. We need to have clear admission criteria and selection criteria for things like ventilators should we get there. We don't want to get into a situation that your access to a ventilator may be determined by your ability, whether you're a member of a medical scheme or not. And I think there's a lot of work behind the scenes to try and avoid that. I think we need to work a little bit harder in dealing with asymptomatic patients that test positive for COVID. We need to get a lot stronger on contact tracing and continue doing that in a meaningful way. We may not always be able to deliver the kind of test that we want, but we can definitely invest in understanding the data that we do get to make sure whatever testing we do is in a targeted and strategic way. And we need to have access to all of the capacity in the country. We can't have a situation where we still have a complete supply chain servicing private sector tests and a public sector supply chain that services tests coming from the public sector, which has led to the kind of delays that we've seen at the NHLS, where at one stage we're running at 14 days, we've now come down to 9 days. So I think we just need to be adaptive as we go along. But I think the thing that's most important is that we need to respond in a universal health system way, and not in this fragmented public sector, private sector way as we move along.
Now, there are instances now that are beginning to emerge, even speaking to Nahau earlier on, of issues, a question of remuneration. For example, you've got overworked nurses who are negotiating for overtime. And this is largely the reason why many healthcare practitioners leave the public sector and they go to the private sector, because I suppose they pay better. And how do we then address that issue of an equitable approach to remuneration?
I think that's always a difficult question to answer, what is appropriate remuneration. But we spend significantly on remunerating our staff. And part of the problem with the South African health system is that our public sector healthcare workers are actually quite well remunerated. In fact, in 2010, we introduced the occupations-specific dispensation, which raised the salaries of a number of categories of public sector healthcare workers. The result of that's been, as the funding started declining for healthcare from 2012 onwards, where we started seeing just like inflation-related increases, our ability to employ more staff has kind of been, how can I say, crowded out by the fact that we couldn't actually afford to add more staff. A doctor or a doctor's make up maybe a third or less than 10% of the health sector capacity, but probably cost us 30% of the health sector salary bill. I think there's a lot of ways that we need to start slicing and dicing and trying to understand whether we have the appropriate mix of staff at the right level. But I don't think that there's ever going to be a situation where we're going to have too many healthcare workers or where healthcare workers are remunerated well enough. I think it's one of those things where we all need to work as a collective, including organized labor, to work into a point of towards something that's in the national interest. But I think now is not necessarily the time to start maybe holding us all to ransom given the situation and the crisis that we're facing.